good immunity, advise them about diet and exercise, prevention of smoking, which also is one of the risk factors for cervical cancer, and a long-term use of oral contraceptives. Although this is a relative risk factor, but we do advise that patients should not use contraceptives, oral contraceptives for a longer period, especially maybe more than 10, 20 years. Sexual health, advise patients about protected sex and also practicing multiple sexual partners. And for HIV positive women, early initiation of antiretroviral medication. These are the non-pharmacological prevention that we can offer our patients. And then the pharmacological prevention available, it's HPV vaccines, and they are most effective strategy available to prevent cervical cancer. And it targets the most common HPV types, especially 16 and 18. All of the vaccines, they do target HPV 16 and 18. So there are 3 types of vaccines available. There's a bivalent vaccine, the Cervarix, which targets HPV 16 and 18. And then there's a quadrivalent HPV vaccine, a Gardasil, which targets HPV 6, 11, 16, and 18. And then there's a new, it's not new, but it's new to South Africa. I think they just launched it last year. But it was developed a long time ago. It's a 9-valent HPV vaccine, the Gardasil 9, which targets 9 of the types of HPV, which I'll share with you later. So the Cervarix, the bivalent, is designed to prevent infection from HPV type 16 and 18 that cause about 70% of the cases, as I discussed before. And it's approved for use in females from 9 years to 25 years. While in some other countries, they approve it until at least 45 years. So it has been shown to be effective for at least just above 7 years. Immunization with Cervarix consists of 3 doses, which are given 0.5 ml via intramuscular injection at 0 months, 1 month, and 3 months. So they have to be given within a year. So the most common adverse reactions are pain, redness, and swelling at the site of an injection, as most of vaccines do, and fatigue, headache, and myalgia and arthralgia. So after injecting this type of vaccines, you have to monitor the patient at least for 15 minutes just to check if they don't have any fainting spells or any of those side effects. And then the second one is the Gardasil, the quadrivalent. So as I said, it protects against HPV types 6, 11, 16, and 18. The 6, 11 mainly cause 90% of the time cause genital wart cases than causing a cervical cancer. So it's also used in females from ages 9 to 45 years of age. It's effective up to 10 years compared to the Cervarix. And it's also given in 3 injections over 6 months within a year. So, but this you give at 0, 2 months, and 6 months, the 0.5 mils. So they all come in 0.5 mils. Alternatively, in some other countries, actually also in South Africa, For females ages 9 to 14, they usually give 2 injections 6 months apart. That was the implementation from our vaccination in South Africa. And also some of the side effects are common. It's pain around the injection and syncope and arthralgia. So you just monitor the patient for 15 minutes after injecting. And then the newest Gardasil is the Gardasil 9. So it's extended HPV protection against 6, 11, 16, 18, 31, 33, 45, 52, 58. So the types that are in bold are the high-risk types that cause up to 90% of cervical cancers. And also it's used in female from 9 to the age of 45 years of age. And it's effective up to 6 years. So it's less effective than, it's like the duration of effectiveness, it's 6 years. And it's also given as the same as the Gardasil, over 3 injections over 6 months, which is 0, 2, and 6 within a year. Yeah, as the Gardasil alternatively, it's also given in 2 injections for for females between 9 and 14 years, and they all have the same side effects profile. So that was the primary prevention. So it's the non-pharmacological and the pharmacological prevention. So secondary prevention of cervical is also a cost-effective strategy to reduce the incidence of and mortality of cervical cancer. So secondary prevention consists of primary cervical screening programs, which are different different in every country. There are 4 methods used for screening, for primary screening, which is pap smear, which is the most commonly used screening tool, where the sample is collected from the cervix to a glass slide, and then it's sent to the laboratory to be examined under a microscope. And HPV test, which is also a newer test that we can do, where you sample the cervical cells and put it in the liquid-based solution, and then they check for the high-risk types of HPV 16, 18, and the other high-risk types. And visual inspection, this method, it is one of the type of methods for primary screening, but it's no longer being used because it has a low sensitivity, and also it's user dependent. So we no longer use this type of method, but we only use it if we are doing a secondary screening via a colposcopy. Liquid-based cytology, also it's a newer method, and it's also the method that we are familiar with these days. I think most people have changed from a conventional pap test to a liquid-based cytology, because here you can do you can examine the cells under a microscope, and also do the HPV testing using the same liquid base. And then so the cytology-based, the liquid-based cytology and the conventional are the ones that are well established in South Africa in the public and private sectors as a primary screening method. So HPV is more sensitive, detecting precancer, and has a better negative predictive value than cytology. But this test has not been approved to our to our cervical screening programs as a primary screening test, but it's available as an additional screening test. So the change to HPV screening will take time in South Africa. So we are still using the conventional and the liquid-based as a first test, as a primary screening test. So this is the program. So the cervical screening program of South Africa. So it's divided into low resource and high resource. But this distinction, sometimes it doesn't work in other areas, because some of the public hospitals, they have high resources, and yeah. So patients are also divided into HIV and negative or unknown, positive, HIV or negative or positive. So for low resource countries, you initiate screening from the age of 25 years, and you exit for patients who are HIV negative or unknown. But before you screen a patient, you need to know their status. So let's just say HIV negative from 25 years, and the exit for low resource, it's 55 years or after a hysterectomy, provided the pap smear before the hysterectomy was normal. And then the interval for the HPV, if you are as a low resource, usually they use cytology, they don't use HPV. So it's usually every 5 years. But if you are using HPV, if you have equipment for HPV screening, the interval will be every 10 years. If the first test is normal, you repeat it after 10 years. For HIV positive or low resource, so you initiate screening at diagnosis of the HIV, and then you never exit. So the patient has to have screening the whole, like until the end. So for HPV, for HIV positive, you do it every 5 years, and for the cytology every three years. And high resource, also you initiate screening at 25. But some other countries or at WHO, they recommend 21 years. Some other countries, they recommend screening if maybe patients are symptomatic, irrespective of the age, are symptomatic, or you suspect that they might have a cervical pre-malignant lesion, and so you initiate at 25, and then exit is at 65 or at hysterectomy for HIV negative high resource health facilities. So the interval for HPV is 5 yearly, and for cytology is every 3 years. And then for HIV positive at diagnosis, you never exit. And then for HPV screening, every 3 years. For cytology, you do it yearly. All right, and then tertiary prevention. So tertiary prevention is by following up the patient after doing the screening test. So you are following up the cytology, or if you did the HPV screening, you are following up. And then it also consists of secondary screening. I'll explain that, and also treating precancer lesions. So the outcomes for cytology screening, either from a conventional or a liquid-based cytology, it can be normal or atypical cells of undetermined significance, or low-grade squamous intraepithelial lesions, high-grade or ASCH, and also atypical glandular cells. So the report can come as one of those. There's a small percentage where it comes as a cervical cancer, but yeah, so there is less than 1% of the time where the pap smear comes as a cervical cancer. Those patients You just need to do a biopsy to confirm. And then, so the secondary screening, it's a colposcopy and/or biopsy. So, and it will report as a cervical intraepithelial neoplasia 1 or cervical, which is equivalent to low grade. And also it can report as a CIN 2 or 3, which is equivalent to high grade. So the treatment methods for tertiary prevention are large loop excision of a transformation zone, which is the most common that we use, and cone biopsy or cold knife biopsy, laser, or a cryo treatment. So these treatments, they are similar in efficacy, and they eradicate the precancer lesions similar. So whichever one that you have in your facility, you can use, and also in keeping in mind of the patient condition or the selection. So, and this is just the natural progression of HPV. So in 20% of the time, from the time of infection, it will progress to low grade in 5 years. And also after low grade, you can, without any treatment or any manage, 20% of the time in 5 years, it will progress to a high grade. And also 20% of the time in 5 years, it will progress to a invasive cancer. 80% of the time they regress. So from low grade to a normal, it can be 80% without any treatment or anything. And also from high grade to low grade, 80% of the time they will regress. But once you have cancer, there's no regression to a high grade or to a low grade. Okay, so when the pap smear comes back as a low grade or ASCAS, what do you do? So this is also divided in low resource and high resource, but depending on how, like you must have a treatment plan for each patient for your practice, and yeah. So a low resource, if a pap smear comes back as a low grade or an ASCAS, so you have to repeat the pap smear in 6 months. And if it's still persistent, after 6 months, you do a colposcopy and or a biopsy. So from the colposcopy, as I said, it can come back as CIN1 or CIN2, 3. So if it comes back as a CIN1 in a low resource head facility, you repeat the cytology in 6 months. And after 6 months, if it's still persistent, then you treat it with the treatments available. And if it comes back as a CIN2-3, you don't repeat after 6 months, you treat the very same time. For a high resource, they do a further step, like they do a secondary screening. So after the pap smear comes back as a low grade or ASCAS, you can order a HPV screening test. If it's negative, if it's negative, you do the cytology and HPV in 1 year. You repeat the cytology and HPV if the HPV is negative. And if the HPV is positive from a low grade or an ASCAS, you do a colposcopy and biopsy. And then from the colposcopy and biopsy, if it comes back normal, you repeat the cytology and HPV in 1 year. But if it comes back as CIN1 or 2 or 3, you treat. And then for a high grade or ASCH, low resource, you treat them, you go straight for treatment. And a high resource, you can do another step, do a colposcopy and a biopsy. And from those results, from a colposcopy or a biopsy, you treat any CIN. And then there's also a typical glandular cells. So all of these patients who come, the pap smear comes back as the cytology comes back as a AGC. They are all required to be done an endocervical sampling or an endometrial sampling, because those glandular cell might come from the endometrial, might be endometrial cancer or endocervical cancer or endocervical premalignant lesions. All right. So in conclusion, yeah, since HPV vaccination was recommended in 2006, infections with HPV types that cause most HPV cancers and genital warts have dropped by 88%, and among teen girls, and also 81% among adult women. So this vaccination is very much effective. And also HPV-based screening is preferred to cytology, although we are not there yet. It's because of its higher sensitivity and allows a longer intervals of doing the test. And so HPV vaccination and the screening are the cornerstone of preventing cervical cancer. And there's a need for improvement of current programs or guidelines of HPV screening. Yeah, as I said, I think I did it in 30 minutes. So yeah, maybe I'm the quickest one. Thank you.
Thank you very much, Chef Doc. Maybe you're the first one now.
Yeah, I'm the first one to do it in 30 minutes.
Yeah, but you covered all the essential points in terms of the prevention of cervical cancer. And,
Yeah.
and thank you very much for this brief and detailed presentation. We don't have questions yet, but I want to encourage all colleagues to please post your questions in the chat box so that Dr. Mndebele can respond to your questions. I'm glad that you also mentioned that this is it's Women's Month and next week is Women's Day. So thank you. And I just want to say in advance to wish all our women a happy Women's Day, and we remember the struggle that women in this country fought, and we do not want to take that for granted. And we also just to celebrate Banyana, who just won their game the other day against Italy, and we wish them all the best in the next coming games, and also the netball team, the SPA Frontiers, who are doing well, and we hope that they will also be able to go into the next round, and just if they can just beat Uganda. I believe this is their pathway to the semifinals. There are a few questions that have just been posted just now, but just before we go into those questions, just to say the prevalence, pardon me if I missed it, but also looking at your practice, how would you rate the prevalence? I know that this presentation was primarily to help to prevent the cervical cancer, but in our communities, was the prevalence, have you seen a downward slide, or it's getting worse?
Yeah, no, I think from my experience, I think we are on a downward slide. So it's improving because of the availability of screening, and also the HPV test that's it's available currently. So yeah, from my experience, I'm seeing a downward. Although in the public sector it's still a problem, but in the private there's a downward prevalence. So yeah, we are getting there.
No, thank you. Actually, I was going to ask about the public sector. I've spent most of my working life in the public sector, and I'm still have a passion for public health. Just to say, but what are the challenges there in the public sector? What are the impediments? Is it the availability of the vaccine or screening? How do we take it from how do we advise government or our colleagues in the public sector?
Yeah, I think the availability of the also HPV vaccine. So the implementation between the ages of 9 and 14, it's there, but the vaccine is not available. So we're not getting enough, we're not immunizing enough children around those ages before they become sexually active. And also the facilities, the availability of screening tests, and also, yeah, the numbers are very high in the public. So it takes 6 to 8 weeks to get results, and also you have to do they do colposcope, which also takes another. Then it's a longer period for patients. Some patients we lose in follow-up, so they get tired of coming to the hospital every time. But yeah, so I think it's those issues. So.
And pap smear is still one of the mostly available tools to use.
Yeah.
But can women just walk into any health facility, public health facility, and easily obtain a pap smear today?
Yes, that's what is.
Not in the private sector. I'm talking about in the public.
Yes, they can. As I said, I think for now they are using 25 years of age and above. But some people, they are still in the old days. They're using 30 years and above, and the interval, sometimes they tell patients interval is 10 years. But as you saw, the interval for a cytology, it's 5 years. So yeah, so maybe some information they're getting misinformed, and yeah, they are not updated, or yeah. So as I said, 25 years, anyone can go to a head facility and say, I'm requesting a pap smear, and get the pap smear.
Yeah. Okay, there's a question from Dr. Kalakala. What are the signs and symptoms of cervical cancer? I mean, any detection, I would be able to, without necessarily. Well, I think if it's signs, you need to examine. That's what it means. But what are the early signs?
So the symptoms usually, it depends on the stage. Even the signs depend on the stage of because cervical cancer, it comes in stages, like stage 1, which is an early stage, stage 2, and stage 3, 4 more advanced. So most patients in the early stages, they'll present with the abnormal uterine, abnormal bleeding, vaginal bleeding, and they might have some pain or discomfort during sexual intercourse, or maybe as I say, contact bleeding. And so in the early stages, they are non-specific. That's why most of the time, if a patient comes, you need to do a speculum. Even from the GPs, they have to have speculums to examine those patients and examine the cervix. And yeah, so late stages, they come with weight loss, and so it differs on the stage, weight loss, and also if maybe there's an obstruction in the urinary system, they also obstruction from the bowel. So it depends on the stage. Some stage 4, especially, it's more advanced. It affects the lungs, and yeah, so it differs with the stage. There's a lot of symptoms, but yeah, the most common one is the PV bleeding and contact bleeding.
Okay, thank you very much. Sbusiso wants to know, in a sexually active patient, do you have to do pap smear before vaccination?
In a sexually, yeah, if a patient comes for a pap smear, you do the pap smear, and you can vaccinate even before you do the pap smear. So, but you have to follow up the result. You don't say you do the pap smear and then you vaccinate, then that's it. Then you have to follow up. If there's a lesion, you treat the lesion, and you continue those steps of treating the pre-malignant lesion. So you vaccinate patients who have never been vaccinated. if it's they can afford or if it's available in the center. So yeah, you can vaccinate and do the pap smear.
Yeah, before you go to the next,
even if patients, even if patients are vaccinated, we have to do pap smears.
you still do the pap
The
smear.
screening has to continue, yeah, even if they are vaccinated against HPV, even if they got it when they are 9 years, 14 years.
Yeah, I think in your slides you do show the stepwise approach as to when do you stop, when do you start, and yeah, because maybe it was a bit fast for some, or people want to have a look at it again. It's a question that we normally get with almost every speaker. Whether are you keen to share your slides?
Yes, I'm keen to share my slides.
Okay, so I think the question, there's someone who asked and wanted to find out.
Okay.
Yeah.
You'll just have to let me know how.
No, you can share them with us, with myself, or
okay.
just come with the clinics, as clinics, and then we'll share them to all those participants who blocked into this evening, those who've got their emails on our database. AK Desai wants to know if a patient had a hysterectomy for a precancerous lesion, how often would you do a pap smear?
Okay, so if a patient, especially maybe an elderly patient who you found she has a CIN 2 or 3 or CIN 1, then you decide, So after the hysterectomy, hysterectomy will come with the histology. So the histology, they will look at the cervix. If you did a total abdominal hysterectomy, I assume, then you remove also the cervix. So the histology will look at the edges of the cervix. If there is a precancer, the precancer lesion, it's there on the edges. And if it's there, you have to do a Volt smear. A Volt smear after 6 months of the hysterectomy. So we call it a Volt smear. And if there's no, if the histology comes back as a total cure, there's no on the edges of the specimen of the cervix, there's no precancerous lesion, those patients are cured. So there's no cervix left, and also there's no precancer lesion. But yeah, so you don't need to do Volt smear. Those patients are done. They are exiting the screening program.
Okay.
So yeah, so it's important to check the histology, what they report on the cervix, and we'll take it from there. Yeah.
Great. And Francois Dubrain wants to know, there are some people who say that only 2 vaccines of Cervarix are needed when older than 18.
And older than, okay. So as I said, the vaccine, usually the immunity is around 7 to 8 years. So actually this vaccine are recombinant vaccine. So it's just for head immunity. It's like a COVID vaccine. So there's no specific guideline how many times you give the vaccine, but as I said, we recommend every 10 years at least that you can give the vaccine. But also the screening will guide you if the patient needs extra, because when you screen, you check the cytology, and it's been normal for years. So you can give the two vaccines after 40 years, then you can after 45 years, then you don't need to give any more vaccines. So until 45, so 18, then you can give at least 3, because it's from 18 to 45, it's how many? It's 20 something years. So the 2, I think they're suggesting that 10 year. So we give it at 18, 28, 38. So yeah.
So it's more than 2.
Yeah, it can be more than 2.
Okay. No, thank you. Wow. We've got Dr. Daniel Mahapa. Dandy, thanks. Good to see that you're connected, looked into one of the obstetricians, also runs
Oh,
brilliant
okay.
webinars. So you know him. He wants you to briefly comment on the sexual decline in the age of sexual debut, on the risk of developing cervical cancer. That, you know, more and more younger people are having sex at a much younger age, and there might be a risk of developing cervical cancer. Any comments on that?
Yeah, so yeah, that one. I've also have seen that, and that we can. It's only the parents that we can advise on that, or the patients and parents. So I think, as I said, from 9 to 14 years, they get the vaccine. So we hope by that time, by 9 and 14, they haven't started having any sexual activity. So that's why we give it at a young age. But yeah, we have seen a rise in early sexual debut, and also younger patients getting cervical cancer as young as 25 years. So that's why the screening is important. And the vaccination is important. If maybe you find a child at 21 who just had a delivery or had a child, so it's important that you screen them after the delivery, like 6 weeks after. Even if they are 18 years, 6 weeks after you do the pap smear, because they have started having sexual intercourse, and also there's evidence that there's a child now. So all the women who have a delivery 6 weeks, please do a screening cytology.
But what is the role of, I mean, the healthcare practitioners? What role can, I mean, we are aware about the risks of early age of sexual activity. Cervical cancer is one of the problems at pregnancy. We've seen that teenage pregnancy no longer be a big issue anymore, because I mean there are lots of teenagers getting pregnant, but the age is going down. You know, we've read somewhere about a 10-year-old being pregnant. What roles? What is the role of the practitioners in society that we can do besides just doing screening? Well, I'm trying to redirect it to a certain line of thought.
Yeah, so we have a role because we do most the counseling, and we offer contraception is also important for these children. So we have to make sure that we do reach as much as we can in contraceptive services, and offer or when you examine someone, even the pediatricians, because we usually see them when they are above 16, and they've already started, and before maybe they were seeing a pediatrician maybe for something else. And so it's important also for the counseling from the early age about contraceptives, and counseling the parents and the children. So contraceptives, it's also important, and also contraceptive also includes condom use and those programs. So
the message of ABC seems to have died down. We are not longer talking about ABC. Well, I think it was mainly about HIV/AIDS, but I think it's even in this here, in this context, wouldn't that be a good concept to talk about abstinence, etc.?
Yeah, it is actually. It is actually. Yeah, it has died off, and we are using a lot of contraceptions and then to offer them condoms and whatnot, because some they are afraid of weight gain, so they just decline the contraceptive. But also a condom is a contraceptive, so you cannot leave it there where the patient says they don't want a pill, like a combined oral or injection or a depot, because they are afraid of weight gain or whatever they are being told out there. So also condom, and as you say, the APC abstinence, and they must be faithful also, and avoid this multiple sexual partners. And it is important to counseling in that order.
Yeah, next question from going back to vaccines. Yuvraj Mittal wants to in HPV positive patients, can one still give the vaccine?
Sorry?
In HPV positive patients, can one still give the vaccine?
Yeah, in HPV positive patients, you can still give the vaccine.
Yeah.
Yeah, you can, because it's a, as I said, it's like a COVID. It's like a herd immunity. It's not like the vaccines that you give in, although we give it before sexual debut, but also it can be given at an early age, even if the patient has HPV. But as you know, as I said on the screening, if you find HPV high risk types, you have to do a colposcope and a biopsy. So yeah, so you treat them and then you can give it. It works for a longer period. So while you are treating, the vaccine creating immunity. So yeah.
You've triggered something in Thabo Mashiho's thinking. Thabo, can you unmute yourself and ask your question? I don't know if it's related to what we're discussing now, but just I see that your hand just went up. It means that you want to.
Hi, how are you?
Fine, and you.
I'm
Welcome
good.
once more. Yeah.
I'm good. As we know, one of the benefits of a medical circumcision is you are somehow immune or minimally likely to be infected with the HPV infection. Have you epidemiologically shown that the men who are circumcised do have this indirect benefit to our female sexual partners?
To decrease HPV?
Yeah, in circumcised men.
Yes, that's what. Yeah, circumcised men. I mean, we know well. I mean, it's well documented that if you are circumcised, there are some minimal chance of being infected with the HPV infection. As that's shown, I mean, indirectly to your female sexual partners, that there's a reduction in terms of cervical cancer in them.
Oh, yeah, that one I haven't come around that if there was a study done about that. But yeah, but all I know that yeah, like for a female to get HPV, I think it doesn't matter from it doesn't matter if the male was circumcised or not circumcised. But I haven't come up with it. I cannot answer that one. I haven't come up with a study that compares uncircumcised and circumcised.
Thanks a lot. Thanks for that honest response. Yeah, okay. Thanks, Dr. Mashir.
Okay. Maybe just an input into that, you know.
Yeah.
I think studies that are available.
Yeah, you've got a poor network. We're losing you there.
Yeah, we are losing you.
Just that with okay. Studies have shown that if you are circumcised, I mean, your female partner is unlikely to have a cervical cancer is reduced by almost 2.5, I think, to 5 times in her lifetime.
Okay.
Doctor, can I request that you share that study with us? Then we can share with other colleagues who are.
Okay.
Just email that study to us, and we'll share it with you. We'll order it.
Okay, thanks.
Thanks for the comment.
Thank you very much, Doc. Yeah, it's a good information about that one. I think, yeah.
Yeah, that's the beauty of having this webinar, that we get people share information, knowledge. Yeah, so it's not that Thank you very much. We're back to, I think we made a comment about this one from Ashraf Ali Mohammed's number was to say that the incidence of teenage pregnancies should still not be started at an earlier age. Last year, about 50,000 teenage pregnancies. We spoke about that much earlier. So you do recommend that screening should be done.
It should actually. Although it's not implemented, but I think it should, because we are seeing a lot. We do it in our practice, that like the teenagers that are pregnant, and we deliver them, and we offer them screening after the delivery.
Yeah, but that is when they present to you because they're pregnant.
Yeah, they already come when,
Yeah, but I think what Dr. Lamad will say that we are aware now. that there's a rise in teenage pregnancy.
Yeah, there is.
But there should be measures now to proactively deal with this and and assist. Yeah.
Yeah, hey, that's another presentation too.
Okay. Yeah. Well, we're going to need to invite you back for that one. Marcus Faison says there seems to be very good evidence that single dose vaccination works just as good as a 3 or more doses. Your comments?
Yeah, there is evidence, especially as I said, if we get them before sexual debut, like so. I don't know if it means the single dose, you mean you give it once, or because as I said, most those vaccines you give it either twice in 1 year or give it 3 times in a year, as I said, 0, 2, and 6 months. So yeah, if we get them early, it works like it works. So there is evidence that if you get it between 9 and 14 years, then there is immunity that can last, because you haven't been exposed to any HPV, or you haven't been exposed to any sexual, yeah. So, but still you need to screen. If they develop it later on, you still need to offer them another dose of vaccination.
But generally, how long does this immunity last? If you catch them?
Yeah, so when you give it early, maybe I didn't share that one, that the immunity can last up to 20 years, or up to 20 or 25 if you give it before any HPV infection or any sexual debut. There is evidence that shows that it can last for some time, and but still, as I said, we need to screen those patients. So yeah, if you give it before sexual debut, then it lasts for some time than when they already have HPV, or when you offer an adult without any screening for HPV, then yeah.
In men, is there room for testing for HPV?
In men, there's room for vaccination against HPV in younger boys also. But testing, I haven't found any screening tests for men. I'm not sure if but yeah, I haven't come across that. How do you test for HPV? But unless maybe there is some genital warts that you see, then you can take a biopsy, then they find that it's HPV or 6 or 9. But yeah.
Yes, he adds that
there's
men
no
also
screening.
Yeah, but he also adds that men do get HPV.
Yeah, they do get HPV. Yeah.
Yeah.
Actually, yeah. Some women they get it from, most women they get it from men. Actually, it's sexually.
Yeah.
Yeah.
So may may you comment on the reluctance of some parents to have their children vaccinated?
Okay, against HPV or against general vaccination? Or
yeah, because we're discussing HPV, but it just it's like when we did with COVID, but I think because they talk about their children, they don't want to, for various reasons, perhaps.
Yeah, most of this is they think maybe it's like COVID, they think this vaccine is gonna cause some sort of disability or those kinds, but yeah, some parents they have different beliefs. Some parents they believe in traditional ways, and they don't believe in vaccinating children until the age of 10, or some they stop even at 5 years, or yeah, so they don't go above that because they are thinking it will cause some problems to their child. So yeah, it's different explanations about this, but yeah.
But have we found that there are some parents who might say, my child is too young, they're not sexually active, why do you want to vaccinate them?
Yeah, that's the thing. Yeah, so you need to explain to them that the vaccine works most when the disease hasn't occurred or anything hasn't occurred. So works best actually, yeah. So yeah, you need to counsel them about this and show them the incident of the cervical cancer that most people are dying from it, and they present very late. Sometimes it's asymptomatic, as I said. You present as a stage 2, like you come with a lesion, or it's an incidental finding during a pap smear that there's a lesion there. The patient that didn't know anything about it, but yeah. So you need to counsel them that it's important. This disease is it's the second most killer in South Africa. Actually, breast cancer is bad. It is more common, but uh, most females die from cervical cancer than breast cancer.
Yeah, that's quite shocking. Yeah.
Yeah.
So it's important that we preach this language of prevention,
Yeah.
vaccination.
Yeah.
And in your presentation, as Marcus Faison says, you indicate that the risk of progression from low risk to high risk is in the order of 20%. Does that justify repeating cytology in 6 months after a low rate result for everyone? They reckon that 20% is a bit low. So why do you repeat this cytology in 6 months?
I don't know if they saw my slide. So cytology, if it's normal, I said you can repeat it in 5 years. Like for a low resource card, even the high resource usually sometimes we are overdoing it. We do it every year, but you can do it after 3 years. So that's why I'm saying 20% is significant for 5 years to progress from high grade to CAT-CAS. So that's why the 6 months I was talking about, if they found pathology, maybe I didn't understand, but yeah, as I said, if they find pathology and you treat you find a low grade, and then you repeat it after 6 months because you want to see if it's still persisting, the low grade, then you have to treat it if it's still persistent. That's why I said 6 months. It's a way if you find the initial screening test is abnormal. So if it's normal, then you can do it after 5 years or 3 years, or after a year if you are adventurous and over treating or over screening. But
okay,
yeah, that's
okay. No, thanks for there are lots of questions. This is it was a short presentation, but the interaction is quite. Thank you very much. I think you elicited quite a number of comments from the short presentation, which is something that you're learning. Mongalim Tim again, thank you very much for such informative presentation. So which vaccine can a doctor or a primary healthcare nurse choose to cover most of the virus that causes cervical cancer? Is there main against specific virus subtypes?
Yeah. So the most effective one, I would say it's the Gardasil 9 because it's extended. It also covers the other high risk besides 16 and 18. Although it's a new vaccine and it might be expensive and it might not be available in the public sector, and some medical aids might not even recognize it and not pay, then the patient has to cough up 1,000 to 2,000. So yeah, but per dose. So it's given in 3 doses, like 0, 2 months, and 6 months. So per dose, so the total will be like around 3 to 5,000 cost. But yeah, it's a very good one because it covers most of the thing. But if you don't have the Gardasil, some medical aids they do the Gardasil, the 4, 6, 11, 16, 18. So some medical aids they do cover for once in 10 years or once in 10 years. Yeah, but in the public sector, I think they only have probably the server, but I need to correct, I need to be sure which one they do have, because it's not clear if they do have or they don't have anything, or they do have the Cervarix. So that one I think we have to, yeah, because the Cervarix it's the most it's the cheapest one, and it's the oldest one. So, yeah.
Yeah, I think if you answered quite a number of colleagues who were asking about which is the choice vaccine to use. Even Bruna Vata has been answered. I won't go back to that question. Then the question about pap smear again. How often is a pap smear indicated in a postmenopausal woman who is not sexually active any longer, but was previously sexually active?
Okay, so in a postmenopausal woman, you screen them as a normal, even if it's normal, then you can increase the interval, like you do it every 5 years until they are reaching 55, then you can stop. But we know after 55 they are postmenopausal, so, and if they are not sexually active, there's no, and they had a previous pap smear when they were less than 55, that was normal. After 55, you don't need to do anything. Like if they had a previous normal pap smear, then you don't need to do anything to them. Like you don't need to screen them.
Yeah.
The high resource center, they go up to 65, but yeah, 55, I think it's especially if they are not sexually active and they had a normal smear when they were younger than 55. Yeah.
Okay, so I think you've just answered. Someone was asking, at what stage do you stop screening?
Oh, okay.
Yeah.
Yeah, as an HIV positive patients, you never stop because of because of their immunity. So those ones will never stop. But the ones who are HIV negative and also they had a normal smear, then 55 years it's acceptable.
Yeah, I think there's a question. So I think we was asking about when you stop screening for cervical cancer. And so Rabutata says, from the age of 65, if the patient has a clear record of negative screening prior to that, stop.
Yeah.
And I think it's about the vaccine, which vaccine to use. We've answered that question. Thanks for this informative Zoom session. And then Professor Makunyan says, in view of the fact that our public sector is burdened with backlogs in all disciplines, it's disappearing. Why do these questions disappear? Okay, there it is. Yeah, in view of the fact that our public sector is burdened with backlogs in all disciplines, do you think there is a need for private-public collaboration in improving screening for cervical cancer?
Yeah, I think there is. So one of my colleagues also was running a free. So I think the private laboratories have to come into the table also, and offer because the pap smear is like what, it's less than 200 or 250, yeah, less than 250. So a liquid-based cytology without because HPV testing it's more expensive. You have to cough up a lot, 5,000 or so to test those high-risk HPV types. So, but for a normal cytology, liquid-based, so I think there have to be some campaigns that one of my colleagues did run a campaign where he did like the first 10 pap smears for any women who comes, they were free, and one of the private laboratories were on board for that, and they agreed, and then yeah. So there is a need for a collaboration, because in private sector, the result usually comes after 1 week, or after a few days actually, than in public. But yeah, so we just need to see if we also can do a free pap smear testing for a certain number of men in 1 year, or in August. We can choose August as a month. Then
yeah, it will be good. Maybe From this webinar, let's set a target for next year, August, that clinics in collaboration with all these gynecologists who are logged in there.
We can
start something to start a public-private partnership to run all these screening tests, pap smears for all our patients in our communities.
Yeah.
You will lead that together with Professor Makunya. Yeah, it's a challenge, but we'll look into that. Let's talk about that. Now, yeah, I mean, like with the urologists, there is going to be later this year a public, private, together with some of the screening for prostate cancer. So which will be done. I think it's possible because we've got some NGOs who are prepared to work with the private sector to do prostate cancer screening. So we can do the same thing for cervical cancer.
Yeah.
Hi, thanks, Dr. Rabotata. I think I like.
Yeah, I can see he's answering
He's answering the question that you were asking. Question: what's the scientific rationale for giving vaccine to patients already infected with HPV? Then he answers and says, "This is not to prevent the patient from getting infected with subtypes that they have." You concur with it?
Yeah, I'm okay with. Yeah, that's why actually. Yeah, that's the main reason. So there's a lot of subtypes of HPV. So yeah.
Okay. Any input on the vaccination of male partners? I think we've dealt with that one. I think we've covered all the questions. And thanks, Dr. Tada, still answering the questions. There's a question from Dr. Malaza. From 45 years, vaccination for cervical cancer cannot be done. I think she wants to know, are you rolling that out after 45 years of age, that you do not do cervical cancer screening?
Yeah, so that's the from the Food and Drug Administration. So they approved it for use from 9 to 45. So yeah, unfortunately you can't, but we know at 45, after 45, you should have done most pap smears in your lifetime, and if we didn't find any pathology or anything, and you've been a normal patient and up until then you don't need vaccine. Or if you have gotten the vaccine before, and yeah, you don't need the vaccine actually after 45, and because you are almost reaching the menopausal state. And yeah, but I'm not saying people who are postmenopausal, they don't have any sexual intercourse or doing anything, but yeah, but still it's been approved for until 45 years. That's the approval. Yeah, so we don't have anything after that.
Thank you very much. This has been one of the most engaging sessions we've ever had. Very brief presentation, but lots of interactions and comments and assistance from some of the colleagues there, Dr. Rabotata and Dr. Mahapa there, Dendi. Thank you very much for joining us. We appreciate that very much. Dr. Kinoshi, I know that I didn't time you, but you are here. If you are able to do the final comments, possible? Dr. Kinoshi? Oh, no, I'm sure you're still muted. But I just want to thank colleagues for.
Okay.
Okay, go ahead. Yeah, thanks.
Yeah, sorry, I was trying to unmute. Yeah, you caught me by surprise, but
I know. Just I was so much absorbed in this conversation. I didn't check who's logged in or not. I know you're always here with us, but yeah, thank you very much for.
One can never be lost for words after hearing quite an inspiring but also informative talk from Dr. Mndebele, reminding all of us about the cervical cancer, that it's one of the endemic conditions in our country and something that we should not forget about. It's been there for decades, and we're not there yet with it, just like conditions like TB and so on, which have been with us. We shouldn't forget them when new pathologies become a burden to us as a population. And thanks very much. I think it was quite informative, quite updated. It's nice to know that our young specialists are always keeping up with new information. and are always willing to share their information with colleagues, general practitioners, and all of us. And I think we encourage our specialists, and it's good to know that, you know, you working within clinics, we have specialists like you who keep up to date. We encourage all the other specialists in this meeting, but also others who may not be here to participate. They can offer themselves to come and teach us about whatever they want to teach us on, but also they can recommend others with particular topics to come and also enlighten us. So it's not just, it shouldn't just be for CPD points. We know that all of you who attend and registered properly will automatically get CPD points from HPCSA. I think the first prize is knowledge, keeping up with the latest in medicine. And I think even the HPCSA themselves, when they came up with a CPD program, the main thing was not just to get the points, but to ensure that the medical profession always keeps up to date with the latest information in whatever field. Thanks very much, Dr. Mndebele. Thanks, Dr. Bila. I think I'll leave it for you to close the session.
Thanks, Dr. Kinoshi, much appreciated, and thanks for joining us and always being there on this webinars. I also want to thank Kamo from the marketing team for always being here with us to make sure that we've got these webinars going, and my team from Toko Masondo supporting, and the Chief Marketing Officer giving guidance there. And so, colleagues, we thank you, and let's meet again next week. Have a good evening.
Thank you.
Thank you, Dr. Bila.